cases in the setting of patients with pancreaticobiliary malignancies requiring diagnostic laparoscopy to exclude peritoneal spread, and that was our first approach. I think what you'll see from the American experience is a little different in that it is really baby steps, and I think our next, as we look forward in the next generation and continue to look as our steps and notes, that the baby steps are important to prove safety and to prove perhaps benefits to our patients. So earlier, Dr. Marks looked at his Google search was a little bit different than mine, but this year there are 44 published reports in PubMed. Of those, 6 currently have human data. Like I said, much of this data is emerging currently and continues to be very early on. This week here at SAGES, I believe either tomorrow or Saturday, there are 2 abstracts and podium presentations on humans. As far as I can tell, there's only 2. There may be more, but the current feasibility and the data has really been demonstrated in animals. We've heard about the grant money that's been released and the other work that continues to be ongoing. Limited to U.S. trials, and I'd like to look at what's been published. Our initial report was published by Jeff Hazy and my partner, who looked at diagnostic for staging in the first 10 patients. Jeff Marks from Case up in Cleveland additionally presented his PEG rescue data. Diagnostic with liver biopsy from Johns Hopkins additionally was published just recently, as well as the recent report of Mark Bessler's transvaginal cholecystectomy also came out this year. Really limited data published in peer-reviewed journals as of yet. To look at our data currently, the staging for pancreatic malignancy, there are now over 20 patients that have been enrolled. The transgastric and laparoscopy have similar results currently. This is an IRB approval for prospective study as well, and so we'll be moving forward looking at a prospective trial evaluating laparoscopy versus peritoneoscopy in the evaluation of patients with pancreatic malignancies for presumed resection. Additionally, we have an initial 26 patients enrolled in a diagnostic trial looking at port site placement for Roux-en-Y gastric bypass. Port placement, safe port placement in the obese patient can be problematic, especially in patients with previous surgery. And so the thought is to use transgastric peritoneoscopy as a visualization imaging for safe trocar placement. Very much baby steps, but really demonstrating the ability to access the peritoneal cavity from the stomach in difficult patients. At the same time, we can obtain this bacterial data that is not part of this talk. Oops, go forward here. In Portland, as Dr. Swanstrom pointed out earlier, transgastric cholecystectomy has been used. They currently have suspended enrollment. They're working in combination with Northwestern group that have 3 patients who've undergone transgastric cholecystectomies with no complications. A total of those patients with transgastric cholecystectomies at those 2 institutions. From San Diego, transvaginal cholecystectomy is a multinational group, and so their total protocol is many more than this. However, in San Diego, 2 transvaginal cholecystectomies, 1 transgastric appendectomy, and 1 transvaginal appendectomy that have now been completed with no untoward events. These are being performed under an appropriate IRB approval as well. This is one of the pictures demonstrating the dissection technique using a small hook cautery going through the endoscope from the San Diego group. Human notes at Columbia, Mark Bessler says that they've completed now 3 patients with a single 3-millimeter umbilical port and no complications doing transvaginal cholecystectomy, and they continue to accrue patients in their group. In Cleveland, one of the early groups, combined endoscopy and laparoscopy for gastric resection has accrued 8 patients, really combining a hybrid technique in patients requiring full thickness gastric resection. PEG rescue has accrued 2 patients following inappropriate or untimely removal of the PEG tube, as well as they're currently using endoscopic ultrasound to map safe access sites and studying the ways to manage safe access without laparoscopy. As was pointed out, laparoscopy is maybe indicated for initial puncture. They're, along with our group, are looking at safe ways to identify the puncture sites in the stomach. The challenges remain significant, and the challenges, I think, can be broken down in a variety of different categories. Clearly technical issues, both the size of the patients and the size of the instruments, instrumentation and visualization, and microbiology, which we've addressed significantly. The ethical risk should be at the forefront of everyone's mind, demonstrating the risk-benefit evaluation and maintaining patient safety. The concepts that exist, this is perhaps a new paradigm, as many speakers have addressed, the teamwork and concept that must exist. In a little while we'll be hearing a debate about who should lead the team, perhaps, or who should be involved with the team, and the financial issues, as been pointed out, are as important as well. Just briefly, we'll go over these and then we'll move on. The size of the technical issues are important. We learned that our experience moving from the lab, where we were using 20 to 40 pound animal models, changes a lot when you go to work in a human model, in a very large patient with a large abdominal cavity. Obviously we're using instruments that may or may not be designed specifically for that, and hopefully, as we've seen today, many instruments are coming along in the pipeline that will help us address this. The microbiology data continues to accumulate, and I think this is an important area of research. We don't know for sure whether sterility and what level of sterility is necessary, and what the ability of the peritoneal cavity to handle a bacterial load is. This I think, demonstrates one of the technical issues very clearly. A liver biopsy being performed on a small granuloma, as necessary to manipulate tissue and dissect tissue, you need to deform the tissue. However, it's very difficult for us to both steer the instrument and deform it without these instruments that are relatively soft, deforming as well. One of the technical issues that need to be addressed. We're using poor tools for the job. I hope that changes. I'm sure it will, and technology will catch up. We talked about the difference between space. Our first patient, one of our first patients, was being from Ohio State, of course, was a linebacker, about 100 kilograms, and so the space inside the abdomen was very large compared to the space inside our animal models, and so it did change our orientation and our plans as well, and makes exploration quite difficult. Imaging's different. We know that our light sources remain very good for working inside the lumen. Outside the lumen, the available light that we need to see at distance is difficult. Clearly there are strategies that we've seen to address this situation, but using current instrumentation, it becomes problematic. Traditionally, surgeons are guided and gastroenterologists by the patient orientation. Even in laparoscopy, many of us have reminded our camera holders from time to time to maintain the orientation, and that continues to help us on a day-to-day basis. That orientation is lost, and we must relearn those landmarks and what we use for orientation. It remains a challenge for us in performing notes. I think this is a perfect example. Here you can clearly see what looks like the posterior wall, the anterior wall of the stomach, but in fact that was the posterior wall. In a patient who had previous surgery and had some deformity. I guess I'm struggling here. You see here, this appears to be the anterior wall of the stomach, like I said, and with increased visualization, you can see it's actually the posterior wall of the stomach that's held up. That ability to identify at a glance where we are within the peritoneal cavity, I think, can be learned. But it does remain a challenge that we'll need to overcome, especially in certain situations of more technical aspects. In light of our current surgical dogma, the question of appropriateness in pursuing this area of research has been raised. Is the potential risk acceptable? Well, I think that the risks need to be carefully monitored, but one cannot hide from the potential advances of technology and our ability to improve patient care. I believe it is reasonable to advance medical science through human experimentation. Many of the advances in health and surgical care throughout the centuries has been demonstrated by this. The registry and appropriate IRB approval is necessary. There is some concepts that are difficult, and that includes the lost opportunity for revenue as we take large amounts of teams and put them into groups that now are performing procedures that may or not be reimbursed. It remains a barrier, especially in the United States, for the advancement of technology and improvement of care, perhaps. It does, and especially for the early on, will increase cost, not only in cost of the time that it takes to do the procedure and the instrumentation. Teamwork skill set needs to be robust and include all the skills necessary. What the label of those team members are, I think, can be addressed separately, but their training needs to include all the different paradigms that we need and the skill sets in order to safely perform the procedures. Obviously, human notes continues to need careful investigation. Our goal is to improve patient care and improve outcomes using the technology and the abilities that we have. It's a good area to do research, and the research needs to continue. I'm excited to be involved with this field. I appreciate the opportunity to be here today. And unfortunately, with the limited work in the U.S. today, it's very difficult to come up with any firm conclusions other than we all need to keep an eye on the horizon. Thank you.